Good morning, ladies and gentlemen. Greetings from Russell's Hall Hospital in Dudley, UK. My name is Keith Siau, and I am the Research Fellow for the Joint Advisory Group on Gastrointestinal Endoscopy. First of all, I would like to thank the editors at GIE for accepting our study and for this video interview. Our study is entitled Performance Indicators in Colonoscopy after Certification for Independent Practice, Outcomes and Predictors of Competence. I would also like to thank my co-authors, James Hodson, Roland Valori, Steve Ward and Paul Dunkley for their roles in this study. The question that underpinned our research is, how do newly independent endoscopists perform when they start practicing endoscopy in a room without their trainer? The premise to this is that colonoscopy is commonly performed and potentially invasive. When endoscopists first perform, they are subject to supervision at all times. In the UK, endoscopists may only perform without an in-room trainer after they have received Provisional Colonoscopy Certification, or PCC. The criteria for PCC are shown in Figure 1. As PCC marks the transition between full-time training and newly independent settings, this provides a unique window to study post-certification and also potentially newly independent colonoscopist performance. This was a key aim of our study. Our study outcomes were based on the unassisted cecal intubation rate. We also studied a metric which we coined DIP, which was short for drop in performance. We defined DIP as trainees with an unassisted cecal intubation rate of less than 90% in the first 50 post-certification procedures. We also assessed for predictors of DIP at trainee and trainer level. The secondary outcomes included other key performance indicators such as moderate to severe discomfort rates, rates of sedation doses exceeding UK guidelines, and the polyp detection rate. We also assessed whether these additional outcomes were affected by endoscopists with DIP. We performed the study by analysing the JETS database, which is a prospectively maintained training portfolio which is used by all endoscopy trainees in the country. The data is required to support certification. Data on all training procedures are manually entered by trainees. An example of an entry is shown in the supplementary file 1. Trainees awarded PCC over a 5-year period between 2011 and 2016 were identified. The JETS procedures starting from their first recorded procedure to their first 50 to 100 post-certification procedures were identified. The study covariates included trainee factors and also trainer factors. We also studied post-certification factors such as magnetic imager use and whether this could affect DIP. So what did our results show? In total, we had 733 trainers who contributed over 250,000 colonoscopy procedures. In terms of the primary outcome, this was presented using a moving average plot over 10 procedures, which showed a linear increment from 200 procedures pre-certification to just over 93% at the point of certification, and after certification, the average cecal intubation rate fell to a minimum of 91% at the 16th procedure, but this reverted to baseline after 100 post-certification procedures. Based on the 733 newly certified trainees, DIP occurred in 18.4%. On univariable analysis, which is shown in Table 2, endoscopists with DIP had lower lifetime procedure counts and differences in main trainer specialty before certification, as well as lower pre-certification cecal intubation rates, lower pre-certification unassisted terminal ileal intubation rates, and also higher rates of moderate to severe discomfort during the procedures. The effect of pre-certification lifetime procedure count on DIP rates is shown in Figure 3. On multivariable analysis, the factors that turned out to be significant were pre-certification cecal intubation rate, which showed that the odds ratio for DIP reduced by approximately 15% for every additional 1% increment in baseline cecal intubation rate, and also those who were trained by non-medical endoscopists were found to have a significantly higher rate of DIP compared to gastroenterologist trainers. Next, because some trainees receive training after PCC, e.g. for polypectomy skills, or those who choose to have ongoing supervision, we split the cecal intubation rates according to frequency of trainer supervision. Next, because some trainees receive training after PCC, e.g. for polypectomy or ad hoc upskilling, we split the data according to frequency of trainer supervision. This showed no difference in DIP rates according to frequency of in-room trainer supervision, i.e. whether trainees performed the procedures independently or with different rates of trainer supervision. Altogether, 78% of procedures were performed independently without an in-room trainer after certification. When we studied the effect of DIP on other performance indicators, trainees with DIP had lower TI intubation rates, higher rates of moderate to severe discomfort, and at a procedural level, rates of sedation use above recommended doses were higher in the DIP group. The DIP group were more likely to need trainer assistance to advance the scope. When physical assistance was required, the person taking over the scope was more likely to complete a procedure in the DIP cohort, which was okay. Finally, in terms of other KPIs, we show that all of these improve significantly as trainees become more experienced as they advance towards certification, with maintained improvements in discomfort rates and sedation dosages after certification, but not in the polyp detection rate. So why is there a DIP, and why is there a difference in DIP rates by trainer? The effect of trainer factors on trainee outcomes have rarely been studied. Part of our findings could be due to case selection bias, whereby more difficult cases are allocated to consultants rather than non-medical endoscopists. Trainees may be shielded from more complicated cases and have less patience during dedicated training lists. Some trainees might have difficulties when adjusting to the newly independent endoscopy setting. And furthermore, our data suggests that those who apply when they have reached the bare minimum procedure requirements are also more likely to be those who DIP. One limitation is that we didn't study these environmental factors to pinpoint the speculated causes of DIP, and additionally, trainee entries could be at risk of self-entry bias. We show that colonoscopy certification is effective. We show that a drop in performance is common in newly independent endoscopists. Those with DIP affects patients adversely. There are some factors which could predict a DIP, and that DIP could be used as a quality metric. So, what does this mean in terms of future practice? This is the first study to our knowledge that explores performance during newly independent practice. DIP could be used as a quality metric of training. This could reflect adequacy of colonoscopy training in preparing one for real-world practice, as DIP is associated with adverse patient outcomes, those with DIP or at risk of DIP could be identified for a period of performance monitoring, additional training, or upskilling. Thank you very much.